Meningococcal meningitis is transmitted by the intake of an infected person or carrier's respiratory droplets or throat secretions. People may become infected either by direct contact with an infected person's secretions in activities such as sharing drinks or kissing, or by indirect means, where someone may become infected by smoking or inhaling after an infected person has coughed or sneezed, or by living in close residence with someone who is infected. The bacteria will then move from its original adherents in the body to the nasopharyngeal mucosa and continue on to infect the submucosa as well. Here, the bacteria quickly multiply and in the majority of cases only build up to a subclinical level. In about 10 to 20% of cases, however, the bacteria are able to enter the bloodstream, cross the blood-brain barrier into the cerebrospinal fluid, and within 2 days begin to develop meningococcal meningitis. The bacteria are able to avoid being detected by our immune system, as N. meningitis coat mimics the exterior of healthy human cells. Because the bacteria appear to be normal, the innate defense system does not detect them. Additionally, N. meningitis has the ability to partake in capsule switching, and can then effectively go undetected by both any naturally attained or vaccine-induced antibodies. It is only when the bacteria has entered the bloodstream and when it crosses the blood-brain barrier that the immune system is able to detect that there is something amiss. In both cases, the body is only able to combat it with an inflammatory response, which is too weak to overcome the infection by that point, and the body can only be saved by an external treatment. Meningococcal meningitis has an average incubation period of 4 days, meaning that from anywhere between 2 to 10 days, the infection will be developing inside the infected person before they begin to show any symptoms. Once the incubation period is over, the infected person will begin to display a variety of symptoms. Infants range from symptoms such as fever, vomiting, and unexplained irritability to screaming, convulsions, and bulging of the skin through spots of the head where the skull has not yet hardened. In severe cases, some infants with a persistent fever will also begin to have seizures and large swollen heads or accumulations of pus below the surface of the skin. With children and adults, meningococcal meningitis will first emerge with symptoms imitating a common upper respiratory infection or sore throat. Within a few days, however, the symptoms will begin to worsen and can progress from symptoms such as stiff neck, light sensitivity, confusion, headaches, dehydration, and muscle pain, to high fever and vomiting. In very serious cases, some infected people suffer from collapsed blood vessels, swelling of the brain, or paralysis of one side of the body. Once a person begins showing symptoms and goes in for a screening and diagnosis, multiple tests can be ordered. A doctor will commonly use either an MRI or CT scan to look at the condition and size of the meninges and spinal cord, or will conduct a spinal tap to test the cerebrospinal fluid for present invasive bacteria. Once it is confirmed that the patient has meningococcal meningitis, a variety of antibiotics can be used to fight the infection, and can usually make a full recovery in 1 to 2 weeks. If the infection is caught within the first 48 hours of the appearance of symptoms and is treated correctly, there is an 85% chance of a survival rate for the patients. If the infection is severe or is not treated right away, the mortality rate spikes up to 50%, and it is likely that 20% of survivors will suffer from brain damage, hearing loss, loss of a limb, or some other resulting disability. Children survivors tend to become much more emotionally dependent and clingy towards their caretakers, are prone to increased temper tantrums, and likely have to relearn all skills they acquired around the time of their infection. Adult survivors tend to report an unusual lack of energy and fatigue, and have found that they struggle to focus, especially during recovery. Having either returned to work or schooling too early can be detrimental to the mental and physical state of the survivors. There are some individuals, age groups, and subgroups that are more at risk of meningococcal meningitis than others. Infants and children are naturally more susceptible because of their new and inexperienced immune system, as are the elderly, as their immune system is weakened and has most likely began to deteriorate. Groups of people who live within close proximity to one another are also at greater risk for contracting meningococcal meningitis because if one person becomes infected, it will likely spread rapidly to all those near them. For this reason, college students living in dorms, military personnel living in tight quarters, and the poor living in tight housing are at higher risk of getting meningococcal meningitis. Those living in the meningitis belt of sub-Saharan Africa are at the greatest risk of becoming infected, as 90% of the world's meningitis cases originate from there. Meningococcal meningitis is so common there because in the dry season, the combination of cold nights and dust winds cause many to contract severe respiratory infections. Additionally, the overcrowding, traditional close-quartered markets, and population displacement due to pilgrimages create optimal conditions for the spread of the infection. Certain habits, lifestyles, and conditions also can increase an individual's chance at contracting meningococcal meningitis. Those who are frequently around smokers, smoke themselves, or go to bars and clubs are at a higher risk. Lastly, those who have had their spleen removed or have certain illnesses that weaken the immune system are at greater risk of getting the infection as well.